Good morning, good afternoon, and good evening, everyone, and welcome to this webinar today on COVID-19 and HIV. It's our second session in this series, and today the focus is on lessons learned from healthcare workers around the world. My name is Dr. Lucy Stackpole-Moore, and I'm the Director of HIV Programs and Advocacy with the International AIDS Society. Thank you very much for joining us today. Our aim for this webinar series is to celebrate the pioneering work of healthcare providers, researchers and communities around the world in the response to COVID-19, and many of us are IAS members, and also to provide an opportunity for these in-depth discussions to look at the COVID pandemic in the context of how it also impacts people living with HIV and what we can learn from the response to HIV and apply it to the COVID-19 pandemic. Before we get started, I have a couple of housekeeping rules to just run by everybody. First off, please note that due to the large number of attendees, all participants are muted. But if you're having any technical difficulties, please do share that in the chat box in Zoom. You can see chat down the bottom there. And then towards the end of the webinar, we've saved around 30 minutes for questions and answers with the panelists. And you'll see also at the bottom of your screen something that says Q&A for questions and answers directly to the panelists that will be moderated and shared as we have time for. So please use both those functions if you have any issues connecting with the with the webinar, and also if you have any specific questions to raise with the speakers following on from the presentation. You can also send questions directly to the IAS over email. The address is coronaquestions@iassociety.org if you have any additional questions or also following on from the webinar today. Without further ado, I'd like to welcome our moderator for today, Dr. Shannon Hayder. She doesn't really need an introduction, but anyway, Dr. Hayder brings to her current position with UNAIDS more than 20 years of international experience in global health, from HIV and infectious diseases and right across towards strengthening health systems as well. She holds a degree in biological sciences from Stanford University and an MD and MPH from Columbia University. Dr. Hayder is board certified in internal medicine, pediatrics and infectious diseases. She has served in key health leadership roles around the world involved in emphasizing accountability, taking innovations and interventions to scale, and securing impact for sustainable responses. And she is currently the Assistant Secretary General and Deputy Executive Director of UNAIDS, and we are absolutely thrilled that she is with us today. Thank you very much and welcome, Shannon.
Thank you so much. Oh, it is such a privilege and an honor to be here today with everyone during these really remarkable times that we're a part of, that we're living. I am a proud IAS member. And when I see the hundreds upon hundreds of people who are participating in this webinar today, I'm just reminded, we are so linked across our world and our roles in both our commitments and missions to passion, but also our respect and eagerness to learn from each other. And so thank you to IAS for pulling together this really timely session for us to really hear from what are now our most experienced world experts on responding to COVID. And as I look at all of the presenters, each one I get more and more excited by, because we really have today the frontline most expertise in the entire world on how to deal with COVID. So thank you to all the presenters in advance for the work you're doing, the wisdom that you are gaining, and your willingness to carve out some of this very special time for us to learn from you today. So without further ado, I am going to be very brief in every introduction so that the bulk of the time can really be on the presentations themselves and to leave some time for our questions. So with that, we will kick off today with Dr. Liang, who will present on lessons learned from China and specifically from Wuhan. So Dr. Liang is the Associate Chief Physician from the Infectious Diseases Department of Zhongnan Hospital of Wuhan University in China. So over to you, Dr. Liang. Thank you very much. And can we share to, there you go.
Can you listen to me?
Yes, we can hear you now.
Okay, I'm so glad to have this chance to share with our experience with our doctors. So I'm Liang. I'm doctors. Worked in the infectious disease department of Zhongnan Hospital of Wuhan University. I worked for COVID-19 from January to the March, about more than 2 months. So I deal with more than 300 patients COVID-19. So I want to share our experience about it with in Wuhan. Okay, next. Okay, as you know, the COVID-19 bring some troubles to us. So for me, I think at first, so many patients come to our patients, our outpatients. In China, we have the outpatient special outpatient for the fever. So if you are fevered, you can visit our outpatient. It's very cheap. So patients have the fever, they will go to the favored outpatient. You can see the photos. This is the wee hours. So for our outpatient, I cannot work in the light, but at that time, so many patients. So we the favored outpatient is was open for whole days. Even like this, we cannot deal with the patients. So we have low. I'm tired. We have low enough doctors to provide service for these patients, and also we have low enough inpatient rooms for this patient, especially for severe patients. So you can see, I never see so many patients in the fever outpatient. It's the first time. So I take these pictures. So share with you. Next. But after we find this pneumonia, so the government and us try my best to stop it. So it's the 23rd January for the lockdown of Wuhan. You can see the street is empty. So it's very strange the experience for me. As a doctor, I can work every day. So every day I walk on the street, only me, no other people. So so I think this lockdown brings some inconvenience to any. So some people, most of the people stay in home. So but the lockdown stopped the virus. So make me have enough time to deal with the patients. After the lockdown, we find our work is better. It's easy to deal with. So I think lockdown is very useful. Next. But the COVID-19 brings some difficult situations for the first the hospital or dealing with only the COVID-19. You know, in China, the HIV/AIDS patients take some ARV medicines from the decide hospital and or CDC. if they meet some health problem, they will go to the decide hospital. But these hospitals are most of these hospitals only for the COVID-19 at that time. So if some patient with OI, some HIV/AIDS patients with OI, they cannot find is difficult for them to find a decide hospital to receive the care. So I meet some HIV/AIDS patients. So it's very difficult. And the second AIDS ARV refilled. We allowed the patient the HIV patient should take the ARV medicine every day, but they every month or every 3 months they will go to the hospital or CDC to refill their ARVs. But the lockdown brings some inconvenience for them. The second is the third constraint is pulmonary infection was misdiagnosed with COVID-19 for HIV/AIDS patient. We know the HIV patient can got some OIs. The OIs, one kind of the OI is PCP. The PCP, if we test it by CT, some is like glass, like is like the COVID-19. So one meet at least five patients was was misdiagnosed. So I will share with you about how we patients. For the first situation, my
Apologies, we seem to be having some sound difficulties. I know Dr. Liang is calling in from his phone. I think we have you back again, Dr. Liang. Please continue.
Okay, continue.
Yes, please. You're fading in and out on your phone, but we can hear you now again. Thank you.
Okay. I think next slides. Okay, I will continue. Next. Yeah. This is the mobile cabin hospital. It's special for some COVID-19 patients. It's very tender COVID-19 patients. So you can see if the patient in this hospital, the is free, and the doctors and the nurse will take care of this patient because they are tender. So if a HIV/AIDS patient got COVID-19 infection, they also can enter these hospitals. The hospital, the doctor and the nurse will take care of this patient. But the most difficulties for AIDS patients with OI, not COVID-19, is very difficult to find a hospital. Because all the most hospitals is changed to the special for COVID-19. So only my hospitals provide some of the rooms and the beds for the AIDS patients. So next. So for the ARVs refill, so because you know the lockdowns make some HIV/AIDS patients is very difficult to get ARVs. ARVs refill. So the government and the CDC respond with special measures. All the HIV/AIDS patients can get the ARVs from the nearest the CDC. For example, the patient got wherever you got your ARVs before the COVID-19, but now you can get the ARVs from the nearest CDC. Whatever, if you find a CDC, you can get the ARVs. Okay, next one. This is the first measure. The first measure. The second measure, you can see all the doctors can. The knockdown is our doctors can deliver the ARVs to patients directly, especially for some rural area. We divide the ARVs in different bags, and the doctors drive the car and deliver the ARVs to patients to their home. This is the second measures. Okay, next. Yeah, the third measures. So we have the 2 express was working at that time. So we also deliver the ARVs by this express. You can see the SF is Shunfeng in China is express. Okay, these three measures. Through these 3 measures, we keep most HIV/AIDS patients can refill their ARVs. Okay, next one. Okay, I was discuss with you about the last difficult situations, the pulmonary infection. So you can see this slide. I will ask you questions: is PCP or COVID-19? But at that time, these patients was misdiagnosis the COVID-19, because we know the PCR for COVID-19 only 15%. Only the accurate is only 15%. At that time, we have low the antibody diagnosis. At that time, we have low this way. So some patient was diagnosed by CT scan, but this patient is the PCP is OIs for HIV/AIDS. So this patient was some I think 5 patients. 5 the HIV/AIDS patient with PCP was diagnosed COVID-19 firstly. They were lived in the inpatient rooms with COVID-19 patients. So I think that is misdiagnosis. So we miss when so I suggest, because the doctors see this patient, they don't know this patient is HIV positive. So some patient is they did not want to another people to know they are HIV positive. So but the doctor think this patient is COVID-19, so make the wrong diagnosis. So I think for the COVID-19 the patient in China or in the another countries, I think they were screened by HIV if the HIV is positive, so this patient maybe is only PCP, not COVID-19. So next one. So this is my presentation. So this is the first time I attended the and this kind of the presentation. I'm nervous. Sorry.
Great, thank you very much. What a great first experience to be sharing. And I think everything from that sheer volume you showed us of patients of fever to the deserted streets except for you, to the real challenge in differentiating PCP from COVID-19. Please do, Dr. Liang, stay online for questions and answers that we will conduct at the end of the session once all presentations have been made. So with that, I'm going to move over to another one of our frontline experts, Dr. Cristina Mussini. She is a governing council member of the IAS for Europe and is a full professor of infectious diseases at the University of Modena and Reggio Emilia since 2011. She is also the director of the Clinic of Infectious Diseases, Azienda Ospedale, I'm not going to get your name right, of your hospital, Universitario Policlinico, Modena, Italy. She received her degree in medicine and surgery from the University of Modena in 1987 and completed a specialization in infectious diseases in 1990. Over to you, Dr. Cristina Mussini. Thank you so much for lessons learned from Italy.
Okay. So what you will see in this 8-minute presentation is what happened in Italy in general and what happened to our patient with HIV infection. Could you give me next one slide? This is, you know, the slides are in Italian because they come from the site of the Ministry of Health. But you can see that the total number, you can see from Totale, total number of patients actually positives are 108,000. But in general, the number of total cases until yesterday, you know, it was 20th of April, it was almost 200, it's 181,000. And we had 24,114 deaths. Next one. So where did it start? It started in Lombardia, that is a region in the north of Italy. You see the bigger dots. And this was really the heart of the epidemic, which happened even if our country was the first to stop direct flight from China. But the problem is that direct flight did not, you know, it's very difficult to close the border because there are, you know, flights with different stops. And there are Italians who go to China for business and then they come back. And so it's very, very complicated. When the first cases were diagnosed, the situation was already in a stage of in an advanced stage. So we saw not just the patient one, but so many patients at the very beginning in that region. And as it happened in Wuhan, we had you know, a very bad situation in intensive care units because of the respirators. My region is the second bigger dots, you can see it. And so you see in Lombardy, there had been almost 70,000 patients, while in Emilia-Romagna, 23,000 patients. If you go to the next one, you see which is the situation lately. you know, in Italy, there has been the lockdown was started on the 10th of March. And while the curve was really increasing, you know, the number of people who acquired the infection is the red line. And you see that there is a decreasing in the total number. In those, there is an even bigger decrease in those who are currently positive. And these are the blue line. There is an increase in those who ill, so, and are discharged from the hospital, while you see that the death line is really decreasing much slowly, because we reach a sort of flat situation. You know, the median age of the Italian population is higher than the Chinese one, and also we have some rules for sending patients to invasive mechanical ventilation. And usually, since the mortality is very high in patients who are older, they tend not to intubate patients who are older than 75. So that's why we continue to have this death rate. Next slide, please. And this decrease is, you know, very important, and it stays there despite an increase in the number of nasal swabs, which are the gray column, while the rate of new positive cases is decreasing, and the rate of the everyday positive, you see that are the red one, is decreasing. So I think that we are really seeing that the lockdown is working, because there is much less virus that is circulating. The next one. And this, you know, is just to show you that the darker, the worse. So Italy with the lockdown really could reach the level of Germany and Spain, who did the same with the lockdown, while other countries like England or Sweden, who made different policies concerning the lockdown, are still having a relevant increase, as Belgium, relevant increase in the new cases. New one? Okay, which were the problems that we faced with our patient with HIV? We are following 1,600 patients with HIV as outpatient in Modena, in the clinic of Modena, but also we are running the metabolic clinic with Giovanni Guaraldi, where we have about 1,500 patients coming from all around Italy for a visit every year. So the problem of the lockdown was obviously that really it happened even before. When the first cases started in our region, we have decided that the workload was so high that we really couldn't maintain open our ambulatory, our outpatient clinic. So we decided to close the ambulatories, and obviously patients coming from different places could not reach the clinic at that time. As the Chinese colleague was saying, the most important problem at the beginning was the drug supply, because we had a dedicated pharmacy that we have to move with all the other patients of the hospital. So we closed our dedicated pharmacy, but we are doing the same. We are shipping the drugs for those who are who have problem of privacy in their hospital, or if they don't have a problem of privacy, but they just want to move to a bigger center, they can go and have the medication delivered in the nearest hospital. The problem was that the patient was scared to come to the hospital, so some of them discontinued treatment, okay? What we are doing now, we are calling the patient who did the blood test before the beginning of the epidemics, and they were already at an appointment that we didn't respect. So we are calling them, we are telling them about their results. And you know, we are following each patient. I mean, each doctor is following his own patients. So our patient have our cellular phone number. The WhatsApp is always open, so they call us. They let us know if they have any problem. So we continue to follow them, but obviously we are wondering how we can create some virtual ambulatory that could respect also the empathy of our ambulatory, and not only having a telephone call. These are my 8 minutes, I think.
Great, thank you so much. And I think seeing these themes of how our clinicians really solve problems immediately on the ground. How do we start to get WhatsApp and telephones for connectivity, but also how do we do better to be able to provide some of that more qualitative emotional and diagnostic support and connection as we go through. So thank you very much. We will go now to Dr. Marta Bofito for lessons learned from the UK. Dr. Marta Bofito is a consultant physician and clinical research lead of the Clinical Research Facility. She is the HIV service lead at Chelsea and Westminster Hospital in London. Dr. Marta, over to you.
Thank you very much, Chair, for the introduction. Hello, everybody. So I'm going to share our experience from the United Kingdom, from London. Next slide, please. I'm going to talk about how we felt that we had to protect people living with HIV from COVID infection if there was a need, and the fear of getting COVID. And how we work with societies like the British HIV Society and the IAS, how we work with communities, we'll go through an example of that, and how we ensure support to people living with HIV that, as you heard already from China and Italy, has been really challenging. And I think it's also worth discussing briefly, how are we going to prepare to the next phase? Is there going to ever be a back to normal after everything we have learned in such a short period of time? Next slide, please. So just to put you in context, the Chelsea Westminster Hospital Clinic is actually 7 outpatients clinic setting all over London, which is quite a large city. We look after approximately 10,000 people living with HIV. It's one of the biggest centers in Europe. We also run the inpatient services for Northwest London. And we also run a daycare unit looking after people with HIV and cancer, and the National Center of HIV Oncology, led by Professor Bauer. So all of that had to be reorganized within a week. So just for you to think about timing, the lockdown in the United Kingdom started on the 23rd of March, as Cristina said, slightly later than Italy, for example, and then other countries in Europe. So next slide, please. So what we did, we created virtual clinics. Everything became a phone call. And with the exception of one big center, which is called 56 Dean Street, which was where some doctors were left and dedicated to look after people living with HIV who actually needed to come to the clinic. So there was one center that was allowing patients who really, really needed to be seen, though, and this would be established over the phone between the doctor and the patient. The support of pharmacy has been incredible. We have HIV pharmacists in every of the single clinics, and they are all shipping antiretroviral drugs. Maybe we were a little bit luckier in the UK because we already had a home service delivery. For some services, it worked very well. So the clinics that you can see in the north of London, above St. Albans, already had all of their patients taking receiving their antiretrovirals at home by post already before the COVID epidemic. For other services, this was a small percentage of people, so we really had to increase the number of people who received the drugs via post. And also you can imagine the amount of people that were stuck in Scotland, somewhere else in England, in Europe, and we had to look after all of that. One of the clinics, the one with the cross, the 10HB, was actually closed completely and transformed within a couple of weeks into a COVID testing hub. We had to move the inpatient service into a clean area because the hospital wards all became COVID wards. So the patients with the HIV that were admitted with the opportunistic infections and other complications, so very vulnerable people, were moved into a clean area. And also we had to move people, the area of people receiving chemotherapy, into again completely another clean area, away from the hospital into a building right next to it. Next slide, please. It was really important to work with societies because of the fear that people had. At the beginning, people living with HIV were getting messages about the fact that COVID could have been worse for people living with HIV. So it was really important, and the help of BIVA and IAS was fundamental to get the message out that actually if people have a CD4 count above 200, are undetectable and take their treatment, the likelihood for them to develop a worse clinical disease in terms of COVID-19 was very low, and there were no data that actually showed that. It was important for people with low CD4 count, however, to shield and make sure they received the treatment if they could, the antiretrovirals. Very important to look about, when possible, at CD4 in people with who stop treatment and initiate opportunistic infection prophylaxis where possible. And the message had to go out, and had to go out quickly for all of these people. And also was really important to look at resources. The Liverpool website, which is the drug-drug interactions website, came out with drug-drug interactions on the COVID drugs, with antiretrovirals and many other drugs very, very quickly, which is really important because, as you know, we are trying to give COVID drug as part of clinical trials, and the knowledge on interactions with what people are taking is fundamental. Next slide. In terms of working with community and being able to support them, informing patients, supporting patients, or supporting people taking PrEP. So this is the example that I'm showing. What happens for what happens with the PrEPster group. So the PrEPster group is a group of activists that looks after people taking PrEP and shares information about the safety and efficacy of PrEP and the availability of PrEP in the UK. So we work with them, and we made sure that it was very clear that there are no data that shows that tenofovir or tenofovir and tricitabine that they're taking for their HIV prophylaxis is protective versus COVID. And this is because of the amount of information that became available that people living with HIV may actually not catch COVID, but I think there's no data to actually state that. And there is a clinical trial that you can see on clinicaltrials.gov that shows that there is a study in Spain looking at whether anti-HIV drugs, HIV PrEP is protected for COVID. All of this, please keep in mind, that was done during redeployment. The majority of doctors or nurses that usually look after people in with HIV were redeployed on the COVID ward. So it's almost like we were doing two jobs at the same time, the telephone clinic, the support for the patient, the prescription and shipment, and being on the COVID wards. Next slide. Next slide, please. So Few words to conclude on the next phase. So what are we going to do now? I mean, the likelihood for us to follow the example of Wuhan and reopen services probably very slowly is very high, is probably around the corner. But are we going to ever go back to normal? Are we going to optimize our services? Are our services going to become virtual services? Can we deliver drugs to patients by post? How much resources can health systems actually save after what we've learned? Can we do viral loads at home and ship it? In London is very popular to have sexual health testing and other kind of testings that are done at home and shipped to the lab by post. However, this will follow after we really understand what we've done wrong, what have we missed. Over this lockdown period, have people with chronic diseases like HIV been unwell? Is there something we should have done that we didn't? How important it is for them to come to the clinic and do their liver tests to see and make sure they're not experiencing toxicities because they are on chronic treatment. So I think there's a very interesting next phase that, although it wasn't a great experience, what we went through might have taught us something new that will hopefully lead us to optimize our services. Thank you very much for your attention.
Thank you very much, Dr. Bofita, and particularly for the notes and the provocative thoughts that you ended on, which is, wow, we made some virtual shifts and some things to make it critically easier for patients during these times. And what are we learning about what might be better, easier, more successful ways to be less burdens on patients and the healthcare system in regular times as well. So look forward to more discussion on that. So with that, we actually, our next scheduled presenter, Dr. Abu-Sittah, is a frontline clinician and has not been able to join us yet. If he's able to join later, we will put Dr. Abu-Sittah back in the queue. So instead, we're going to skip to lessons from Kenya with Dr. Catherine Ngugi. So Dr. Ngugi is the head of the National AIDS and STI Control Program, Kenya NASCOP, at the Ministry of Health in Kenya. She's a public health specialist trained in Kenya, South Africa, and New Zealand on public health and HIV program management. She's been a principal investigator at the National and East Africa community on several programs aimed at addressing key health issues from sexually transmitted infections to newborn child and adolescent health, to early infant diagnosis, to mother-to-child transmission, PrEP, and PEP. So with that, over to you, Dr. Ngugi, for lessons learned from Kenya so far. Thank you.
Good afternoon. I know that it's good morning here. It's in afternoon in Kenya. Thank you so much for the great introduction. And I'm learning also as well from the other countries, from China, from Italy, from London, and how they're dealing with this COVID. I'll be sharing on in Kenya in terms of how we are responding, especially in HIV and STI, offering HIV and STI services during this COVID-19 pandemic. The challenges we have so far and some of the adjustments that we have had to do so as to ensure that we accommodate and continue our services to our clients. Next slide, please. So this is just a snapshot of where we are. Yesterday we had around confirmed cases of 281. Yesterday we had 11 new cases, 69 who have already recovered, and then we had deaths which are around 14. We have around established 33 quarantine centers. On forward, currently we had 483 clients, but as well, those ones are from the ones who had traveled and the ones who had come to contact with. The distribution in the country, as you can see, we have fewer counties which have been where we have had COVID cases already confirmed. Next slide, please. So the government has put in some measures to ensure we see how we can control the infection of COVID-19, like banning on social gatherings. We have had mandatory masks now in use within the public. As you can see from that picture, the issue to do with 1.5 meters. And in every, like that picture is in a bank where they're going to get service from the bank, so they are raining up outside. We have had 7 p.m. to 5 a.m. curfew, and then restricted access to infected counties. You know, counties where we have had confirmed cases more than 2 or 3, Nairobi, Kilifi, Mombasa, and Kwale. And then we have set up mandatory quarantine centers. So far, we have had more than 2,500 clients who have gone through our quarantine centers. And after the 14 days, when we have tested tested them and they found that they're negative, then they're allowed to go home if they were observing the quarantine regulations and setup requirements. Next slide, please. So next slide, please. So we go deep to the discussions regarding now the previous slide, please. Previous slide, kindly. Thank you. So we have a total population of 47 million in Kenya. Our HIV prevalence is 4.9. And the people living with HIV, we have around 1.3, but 1.2 are the ones on treatment. And then we have around 139,000. So the areas of concern, and as even I discussed, I think last week, part 1 is we have had now to limit the face-to-face follow-ups within our clinics. And then we have issues to do with the diversion of our healthcare workers to attend to the COVID-19 response within the country. And then, but now we gave up a comprehensive guidance as HIV and STI program. And one of the issues was implementation of multi-month dispensing of drugs. We allowed now 3 months, despite the viral load measure ITs. And so as we can decongest the clinics and as well protect. Remember, within the first few weeks, there was information that people who are a bit immune suppressed, they are at risk. So we did not really want to put our clients at risk. Then the other part is HIV commodity security. So far we have secured we have up to 4 months, until around September we are safe. We have the drugs. We have several shipments coming and they are overseas. And so we are happy about that. But as well, this month we allowed counties when they are ordering their drugs, they ordered 1 month extra to ensure that they can be able to accommodate clients who get 3 months dispensing of drugs. And as well, we have concerns, especially on vulnerable populations, especially the KP. And I think I'll discuss that in the next slides as we go along. Next slide, please. In care and treatment services, and more it's care and treatment and support services, we have ensured that we have implemented the 3 multi-month dispensing, and then we have spaced out our daily appointments, giving clients exact times of appointments and ensuring that we cluster patients per hour to avoid crowding within our comprehensive care clinics. And most clients have been called and given 3 months of ART. The ones who in the month, for example, of March, who had already collected like 1 month, now we call them back. Viral load monitoring is ongoing, and all regional laboratories are operational. There are around 10 of them in the country. And as well, we are utilizing the viral load and gene expert platforms for mass testing in case of reducing operations and to ensure that we prioritize our unstable clients. And as well, we are utilizing CAGs and to distribute ART. And counties with low stock levels, we are really supporting them to ensure that they do timely orders so they can have enough stocks within their counties so they can issue to the clients the 3 months. Next slide, please. In regarding to HIV testing services, we are ensuring that we really want to utilize HIV self-testing. Currently, it's free within our public health facilities. And as well, the people who can be able to afford it cheaper, it's around $5. And as well, we ensuring that the clients who really have to go through the HIV testing within the facilities and get the counseling services, that we use the clients or the healthcare workers use the measures to ensure that they protect themselves as well as protect the clients. Triaging it definitely has affected all testing centers within the country. PMTCT, we still have a challenge, and honestly, we fear the consequences after this COVID, because issues to do with, PMTCT, we have not been doing well. Currently, we are at 10.8% in terms of mother-to-child transmission rate, which is quite a bit high. And we are fearing that because mothers now, most of them are fearing coming to the facilities. What does that mean? That are we going to have more mother-to-child transmission of HIV? And so, for example, tomorrow we are going to have a call with our partners and our counties to see how do we assess where we are and which measures do we put in special contingency because we can protect our mothers. And we have had a very big challenge, not only during this COVID pandemic you are facing, but even last year and last year but one, we have had low stocks of nevirapine and zidovudine in the country, and which now even makes it worse because the suppliers who are supplying us now, they are citing issues of APIs, and so we don't know exactly what to do regarding to that, and we may end up revising our how we are going to address the raw stocks, either by revising the regimens that we give, but it is still a very big challenge to us. Next slide, please. Key populations in Kenya, and I think I highlighted this one before, we're having issues with it, in knowing that they are at risk, and we have definite high mobility and close physical contacts with others through social and sexual practices. We have people who are KPs who are positive, but they are not on treatment, definitely in others who have not suppressed. So we are fearing for them being at a higher risk to acquire corona. And then even with the way things are, without having any treatment, and even them not being, regarded, recognized in the country, which is still a challenge. How do we address the gaps that we are seeing right now? Now, most KPs experience a disproportionate burden of poverty and definitely marginalization and stigma, and discrimination makes it more severe during this time. But what we have is we are working with the communities and the CSOs to see how do we continue the services despite the challenges that we are having right now. And so, next slide, please. And thus, we have developed and disseminated several circulars and guidelines. Issues as a coordination of partners, definitely virtually, to see how do we respond to the gaps we're having. One of the other big gaps we're having is mobile. We don't match clinics, and in one of the methadone clinics, we have had one of the clinicians testing positive. So, for example, last week we had now to test all 600 clients who are receiving methadone from that clinic. And so now we have said we want to utilize mobile match services for the country, for the people who inject drugs, which can be moving from different towns. So for that area, apart from testing them, now we have fumigated the sites, we have divided the teams. Now we have like 4 teams in that. We had previously even 4 teams. So what happened is one of the team, we had one of the clinicians getting infected. So it means that the other 3 teams can continue when we self-quarantine this one and ensure as well we test the clients. We have several KP teams are doing very well and national coordination is very good. That we are having, we have virtual meetings with the community, see what is their challenges and we can address them. And then definitely lobbying for commodities and resource mobilization for them. Next slide. That is one of the clinics where a prisoner is receiving methadone. And I think I had already discussed most of these, mobile match dispensation, use of vans for service delivery to KPs in their homes or preferred locations, provision and promotion of HIV self-testing among KPs. That is what's among the interventions that we have put during this time. Next. Those are the challenges we are having, especially, and I think this is global, in the inadequate supply of PPEs within the KP programming, and as well, closures of several dices and hotspots as well, and lack of information that we can really give our clients and as well healthcare workers within the KP programming in the country, so as they can be able to learn more on it, and inadequate communication. Next slide, please. So that's the areas that we are doing. Those are some of the platforms that we are utilizing to ensure that we continue the services. Apologies. And as well, to ensure that we continue in touch with not only at the national level, but as well at the counties. So as we can have, look into the gaps and responding to them in time, and knowing that all of us are learning during this time. Next, please. I think I had already addressed that, but so far we do not have ART stock out. We have given out the 4 months buffer stocks for the counties, and all counties are being supported by the HIV orders for ART. Next. Those are some of the emerging issues, and I think they were raised up by some of the public within the forum of the IAS, that the questions to us we're having several rise of gender-based violence issues, not only even within HIV programming, but even HIV and STI programming, but within the country. And not only, they don't think that only lies only into Kenya. And definitely we need to support people living in HIV in vulnerable households, especially with food rations, and the impacts of COVID-19. Definitely we do not have data at all. And as my colleague was presented from London, is that we do not have evidence so far on the impact or the effect of COVID-19 on HIV positive clients. Next. And so for us, that's what we have. Maybe if anyone has any questions, then I can address them as we continue. Thank you, and stay safe.
Great, thank you so much, Dr. Ngugi. This was really fantastic. And I think thank you for highlighting this real acceleration you all did for 3-month, multi-month dispensing, for ART, for PrEP, this mobile mat issue, this looking at stock confidence and security down to county level, as well as really highlighting some of the worries around MTCT and some of the specific key population programs and services, some of the concerns of enhanced and extra marginalization and what that means for socioeconomic needs, as well as highlighting the amount of virtual collaboration for HIV that you're continuing. With that, we will go ahead and move on to South Africa. And again, I'd ask the previous presenters to hang around. We'll take all questions at the end. We're actually going to skip to Prof. Menches, and we're having a hard time getting a hold of him. So we'll go first to Dr. Tracy Flowers. Dr. Flowers. Oh, you're here. Excellent. Yeah. Well, we won't skip then. We'll go in our planned order. So lessons learned from South Africa, #1, over to Professor Graham, who's an infectious disease physician from the University of Cape Town in South Africa. Over to you, Dr. Menches.
Great, thanks, Dr. Hayder. So I just want to preface my talk by saying this, what I'm going to say really is perspectives from the early phase of the COVID-19 epidemic in South Africa. And so what I'm going to be mainly discussing is the challenges that we anticipate, some of our early clinical experience, and the plans that we have for dealing with COVID-19 in the context of a country with a large pre-existing epidemics of both HIV and TB. So next slide. So South Africa, the first case of COVID-19 was diagnosed on the 5th of March. And probably the first 200 or so cases of COVID-19 diagnosed in South Africa were all imported by people returning from travel to Europe. And a national lockdown was imposed in South Africa 3 weeks after the first case was diagnosed, when there were only just over 1,000 cases diagnosed in the country. So relatively early compared to other countries that the lockdown was imposed, and involved people being asked to stay at home and only to travel for essential tasks and services. The result of this lockdown has been that we have seen a blunting of the curve. And you can see that over the last 3 or 4 weeks, we've gone from around 1,000 cases to around 3,000 cases. And if you look on the left-hand graph, you'll see South Africa in red there. And just note that this is a logarithmic curve, and you can see that our curve has not gone up as steeply as some other countries that we've heard from today. And on the right-hand side, you can see that around about the time that the lockdown was imposed, there was a decrease in the number of new cases diagnosed daily, but that is climbing again, and we are seeing increasing amounts of now community transmission across the country. So from 2 days ago, there were just over 3,000 cases in South Africa, 54 deaths recorded to date, and over 100,000 tests done. Next slide. So as we look forward in time, and what we anticipate in South Africa is that we will need to ease our lockdown. It's becoming increasingly apparent that the social and economic cost of our lockdown is not sustainable, and we're going to have to ease the lockdown while implementing mitigation factors and public health measures to try and minimize the impact of the COVID-19 epidemic on South Africa, but we cannot sustain a harsh lockdown for much longer. And as we look forward in time, we do anticipate that there will be a dramatic increase in cases. The scale of the epidemic is obviously, and its impact in terms of outcomes is obviously dependent on a number of local factors. And some of the mitigating factors are the fact that we had a very early lockdown, which has allowed time for our health services and public health interventions to be prepared. Another important thing that might count in our favor is the age structure of our population. So only 5% of our population are over the age of 65. And if you look at Spain and Italy, that's over 20%. So we know that younger population are less likely to have the high mortality rates that have been seen in some of those countries with an older population. But there are a number of factors in South Africa that don't count in our favor, and that one is obviously that we have the largest population of HIV positive people living with HIV in the world, with just close on 8 million people. And many of those patients are not virally suppressed on antiretroviral therapy. And the concern is, and there's no data to date, but the concern is that patients not with advanced immunosuppression might have worse outcomes with COVID-19. We also have a higher incidence of TB, roughly 500 per 100,000 of the population per year, and many people living in our communities with structural lung disease as a consequence of previous TB, and those patients might, and I emphasize might, be at higher risk of severe COVID because of their underlying lung disease. Another factor has been shown that obesity and type 2 diabetes are associated with worse outcome, and the obesity rates in South Africa are the highest in the continent. We also have substantial prevalence of type 2 diabetes. And in our poor communities, there's great challenges with physical distancing, both within communities because of overcrowded housing, as well as in public transport. And there are deficiencies in our public health system, even though there has been time to prepare, that are likely to be exposed as we go forward. So next slide. So I just want to give you a perspective from the facility that I work at, which is Reggio Hospital, one of 2 public sector tertiary hospitals in Cape Town, and how we've been preparing our services for the COVID-19 epidemic. Essentially, the non-COVID services have been downscaled to emergency services. We've opened a COVID-19 testing center. We have 2 wards dedicated for persons under investigation, where we are seeing up to 20 admissions a day. And we have, at this stage, 1 COVID-19 ward, but have plans to expand as the needs increase. We've managed 12 COVID-19 inpatients so far. Many patients have been managed either at home or in a hotel facility if they're clinically stable. We've so far had 4 patients ventilated at our hospital, with plans to participate in the WHO Solidarity Trial that we're preparing our permissions with regard to that. Next slide. So these are some of the sort of unique issues with respect to managing COVID-19 in the context of a substantial HIV prevalence in our population, as well as the TB incidents that I've spoken about. All patients who are under investigation for COVID in our hospital have an HIV test. We obviously would find out about the ARV history and keep them on their ARVs during hospital admission. If patients are HIV positive, and this was alluded to in the first talk, obviously have a broader differential diagnosis for pulmonary pathology than an HIV negative person. We need to particularly consider PCP. Patients with low CD4 counts we know can have pulmonary TB with atypical lower zone infiltrates that may mimic COVID-19, and then other conditions like pulmonary cryptococcosis also need to be considered. It's becoming increasingly apparent both at this tertiary level as well as in the secondary and primary levels that patients can present with a differential diagnosis that includes both COVID-19 and TB, especially if there's been a recent onset of symptoms or a recent worsening of respiratory status. And our approach at the hospital level is those patients where the differential diagnosis COVID-19 and TB are being managed where possible in a PUI side ward with appropriate PPE, including N95 masks for the healthcare workers. A COVID swab is performed and a TB sputum is sent, and then management dictated by the results of those. We also, as I said, many patients, people living in our society with post-TB structural lung disease, post-TB bronchiectasis. We're seeing patients who are coming in with infective exacerbations where COVID-19 is a consideration, and those patients are admitted as PUIs and treated for infective exacerbations while awaiting the result. And our plan is that patients who are newly diagnosed with HIV or HIV not on antiretrovirals and been diagnosed with COVID-19, not on ART, we will wait for clinical stabilization and start the ART 2 weeks after the COVID-19 diagnosis and not start immediately. And perhaps we could go into discussing some of the rationale for that in the discussion time. But as I said, that's not evidence-based, that's our plan. Next slide. So I just briefly want to show you 3 examples of patients who have been through our service, the PUI service as well as the COVID positive service in the 3rd case. So the first really just brings back the point that, you know, patients with advanced HIV, this patient presented with a new onset cough and shortness of breath with recent deterioration, and the diagnosis, the empiric diagnosis was one of PCP. Patient was also found to be plasma cryptococcal antigen positive, so the infiltrate could have also been due to cryptococcosis. Is being treated for both PCP and cryptococcosis. Was investigated for COVID, and that was negative. So the patient was in our PUI ward. When the COVID result was negative, was sent to the general ward. Second, another example of a patient who is admitted as a PUI patient who had vertical transmission of HIV, now 24 years old, previous TB with bronchiectasis, severe bronchiectasis, admitted with a respiratory deterioration, was in the PUI ward when the COVID negative result came back, was transferred into the general ward. And just to show you this, on the 3rd example is an HIV negative patient who was admitted with symptoms compatible with COVID-19. Test was positive and was transferred to the COVID positive ward, just to show you that, you know, these pathologies on the chest x-ray are very similar. And that's what we're going to have to deal with a background of substantial lung disease in our population, as well as pulmonary pathologies that can mimic COVID. And obviously, we will work those patients up for COVID while treating the potential differential diagnoses. And to say at this stage, we haven't managed a patient who's HIV positive with COVID at our hospital yet, but obviously anticipating that. Next slide. So for the final slide, I just wanted to touch on an issue regarding antiretroviral therapy. That in South Africa, there's roughly 4 to 5 million people on antiretroviral therapy. The practice in the public sector is that those patients usually come and get their medication either every 1 to 2 months. They might belong to an ARV club and get their medication there. But with the realization that we want to minimize contact between people in congregate settings, as well as minimize contacts with the healthcare sector to reduce the risk of COVID infection, the South African HIV Clinician Society is advocating that patients who are stable, have been on ART and are clinically stable and well, should receive 6 monthly supplies of antiretroviral therapy. Patients where eligible should be switched to a dolutegravir regimen because that is obviously more robust. And it's only those patients who need clinical monitoring or particular adherence support should be attending facilities. The next speaker, Tracy, is going to speak in far greater detail about the measures in place in Khayelitsha to support adherence, as well as provide access to antiretroviral therapy for patients on antiretroviral therapy in the community. So thanks very much.
Great, thank you so much for that experience and sharing, as you called it, early experience, but very concentrated experience as well. I think in particular, this issue of differential diagnosis among HIV and TB patients, and I do hope we will have time in the questions to get to the ART initiation at 2 weeks. As ID doc, I love the consideration being taken into account to avoid immune reconstitution syndrome, potentially in a coronavirus where we know a lot of the sequelae seem to be related to inflammation. So with that, we will actually move on over to Dr. Tracy Flowers. Dr. Flowers works for MSF Khayelitsha in South Africa. He's the manager of the Welcome Service, a differentiated service delivery model for patients that are struggling with HIV in some way. And I think all of us on the phone are quite aware that Khayelitsha and the Medicine Sans Frontières program has been instrumental to the development of many of these differentiated services, pickup of medicines, community-based delivery, multi-month dispensing, that are what we've been relying on to start innovate and go to scale beyond this. So really looking forward to hearing your experiences. Dr. Tracy, over to you.
Great, thank you so much for this opportunity. And thank you so much, Prof, for providing that broader context and background as well. So for those of you that don't know Khayelitsha, it's a very large peri-urban informal settlement, and there are just over 500,000 people living there in a very close proximity setting. You can go to the next slide, please. And there's a very significant burden of HIV in Khayelitsha with around 50,000 patients on ART. And there are already multiple differentiated service delivery models available for patients. And when I refer to a DSD, for those that aren't familiar with the term, it's really just a model that aims to simplify or adapt ART services in some way to be more patient-centered and reduce the burden on the healthcare system. So the majority of stable patients are in adherence clubs, which are groups of up to 30 suppressed patients that received pre-packed ART from a lay counselor every 2 months and have 2 annual clinical visits. So in Khayelitsha, we currently have 53 COVID cases, and this is also on a backdrop of a national expansion of community screening and testing and preparation of primary care facilities through the decanting of stable patients into other service delivery models. Next slide, please. So one of the first DSD adaptations that I'm going to speak about for stable patients are those of the adherence clubs. So the main changes here have included switching from in-person support to providing advice leaflets and telephonic counseling, as well as strategically redistributing dates and combining visits so that there's minimal patient load at facilities. And some of these visits, as you can see in these pictures, are also being held outside of the facilities or at community sites. And we've tried to drop non-essential visits, and for example, buddies are able to collect for more than one patient. But obviously these changes don't come without logistical challenges, and there need to be creation of systems to make sure that patients are adequately followed up and supported during this process. Next slide, please. So there have also been 2 newer service delivery models that we've been using during this time. The first of which is the expansion of home delivery to include ART patients. So here, pre-packed medications are delivered by community care workers to patients' homes. Obviously, patients are contacted prior to that to ensure that they are happy for medication to be delivered. And then the second is providing longer ART refills to patients. And this COVID pandemic has coincided with the national rollout of the new first-line TLD, meaning that there's also limited supply of the previous first-line TLE. So stable patients do need to be switched, and this obviously requires clinical review. So some of the measures by the Department of Health have been to allow for longer scripts to be issued, so 4 months instead of 2 months, and also longer validity of scripts. And something that's been really helpful here have been group information sessions prior to consent. But with both of these differentiated service delivery models and expansions, there's again mostly logistical challenges. Staff need support. There needs to be adequate stock and adequate pharmacy monitoring, especially. Next slide, please. So something that we really are focusing on at MSF are what about patients that are on ART but are struggling in some way. So we run a differentiated service delivery model called the Welcome Service, and that's for patients that are struggling with the management of their HIV, and it includes a spectrum of patients from those that have high viral loads right through to those that have disengaged from care, either intermittently or completely. And this support is done through supportive tools for clinical and psychosocial management with an advanced HIV focus. And I think it might seem to some like a luxury to focus on patients like this at a time like this, but it's actually a necessary component of the COVID response in our setting, because patients who are struggling with their ART are particularly vulnerable at this time. I think one of the first things to recognize is that many of the reasons that patients struggle with their ART are driven by social determinants of health, and these problems are now magnified, and it could actually be the response that we have to COVID that could put them at greater risk. And then obviously there are the important clinical concerns to consider that we don't yet know the full impact of. And just to note that we know that patients who are struggling with ART do place a greater burden on the healthcare system because they do require more time, they do require more resources, and something we're obviously trying to do very actively during this pandemic is to find ways to reduce burden on the healthcare system. So what we're looking at is what can be done remotely. And we don't have all the answers, but some of the things that we are trying are, for example, linkage to and from the district hospital with telephonic support from one of our nurses, telephonic counseling and clinical follow-up for these patients, and then providing patients who are restarting after a period of disengagement with 2 months supply of ART. And this was mentioned by one of the speakers earlier, but I think one of the helpful byproducts of clearing and decanting facilities for social distancing means that we can potentially make the primary healthcare facilities more available for patients that actually necessitate clinician care and management. And this is possibly a positive byproduct that we could continue beyond the COVID response. Next slide, please. So some key considerations from our side. Obviously, we're doing this in a township setting, and here there is very limited capacity for basic principles of social distancing, hand hygiene, and often there are other social factors that may actually present a greater threat to some people than COVID does. And so actively involving the community and sending clear messages to the community is really essential from the start of this response. I think we do have somewhat of a window of opportunity to review patients now and decant facilities of stable patients as much as possible. And I think it's also an opportunity to be quite creative in terms of looking at alternative methods to support patients while minimizing contact. So some of these have been mentioned as well, but telephonic consults and counseling, and utilizing powerful tools like social media. And we do also need to consider going that one step further. So in terms of like the home delivery that I spoke about, is this not something that we could expand even further by adding in family planning and the flu vaccine and TPT? And with longer refills, should we not be providing even more? So 6 months as supply allows, and 4 months for patients that are already on PrEP. Next slide, please. And I just want to end off on this point that I have already made, that those that are struggling with ART in some way during this pandemic are potentially at greater risk of being unsupported and more vulnerable. And I think we need to look at them proactively as part of the response. Some points to just consider as well is that those that do have high viral loads but are already in programs like adherence clubs should probably remain there, because we do have some evidence to suggest that resuppression is better if they remain in the clubs than if they return to facility care. And we do also need to at some point think about patients that don't know their status and consider testing them and initiating them through community models and oral self-testing. And just to end off and say that there are going to be many lessons that we can learn from this pandemic. There's going to be many healthcare system changes that we make and that we are already putting in place, some of which may actually be very helpful to keep long-term, allowing for primary care to be more accessible to those that require it in the future. Thank you.
Great, thank you so much for that great sort of frontline and creative examples. And I think, you know, what you highlight in terms of the community engagement and messaging and social media platforms, both for support, but also frankly, to build trust and connection. This ability to be even more creative, to minimize contact and facility contact, as well as this, how do we add more to the home delivery? And how do we start to reimagine the future healthcare system that sees these techniques as more of a standard and less of as an optional? I think that we are able to go back and get our presenter that we missed early on to learn lessons from Lebanon. I believe Dr. Abu-Sittah is online with us. Dr. Ghassan Abu-Sittah is a British Palestinian professor of plastic and reconstructive surgery. In 2012, he became the head of the Division of Plastic and Reconstructive Surgery at American University in Beirut. And in 2015, he co-founded and became the director of the Conflict Medicine Program at the Global Health Institute at an American University in Beirut. He continues to be a senior clinical lecturer at Queen Mary University of London, and he's worked as a war surgeon in Iraq, Syria, South Lebanon, and during 3 wars at the Gaza Strip. So someone who is quite familiar with flexibility, rapid response, emergency, and humanitarian situations. Before I hand over to Dr. Abu-Sittah, I just want to also mention as moderator, I'm going to be handing over the Q&A session after Dr. Abu-Sittah to Lucy from IAS. And just thank again all of the presenters for sharing their amazing wisdom today. So over to you, Dr. Abu-Sittah. Thank you very much.
توطي صوتها?
Yes, we can hear you.
Hello? Can you hear me? Okay. So thank you very much for inviting me, even though I do feel a bit of an imposter in such a company. What I want to do is actually show how this pandemic has acted as a stressor for not only health systems and health politics in the region, but also as a stressor for power dynamics and therapeutic spaces within 2 places that I'm involved in a kind of pastoral advisory care for health management and the response to COVID, and that's Lebanon and the Gaza Strip. So suddenly, with this pandemic, we are able to see a world that has lit up like a global Christmas tree of power structures and power gradients. And the stressor of the pandemic has shown the essence of a lot of health systems from the northern hemisphere to the south, to countries of low and middle income economies. And with Gaza, it offers a kind of unique opportunity to examine the interplay between politics and the pandemic. So as you all know, Gaza is been under siege, almost hermetically sealed for the last decade and a half. Entrance into Gaza and is limited to two crossings. One, which is the Rafah crossing with Egypt on the Sinai side, and the second crossing, which is the Erez crossing with the Israelis on the northern side of the Gaza. And that almost politically imposed quarantine has acted as both a blessing for Gaza and also a harbinger of what's to come if, God forbid, the pandemic so Gaza, as you well know, instituted a lockdown both internally and as a result of the lockdown imposed by the Egyptian government and the Israeli authorities. And so was able to control the number of people coming in Gaza and place them almost exclusively in quarantine. And the reason for that is one of the limiting factors in Gaza was, and still is, the number of testing kits. And so Gaza the authorities in Gaza were allowing travelers in through Rafah in sufficient numbers that they were housed in schools and in hotels. And the quarantine period was for 28 days. And as the facilities became vacant, they would allow a new influx of people coming back into Gaza. This meant that the little in terms of testing kits were used, one, to protect the people working in the quarantine facilities, and two, to test the returning patients before they were allowed into the community. The problem remains is that there is zero capacity for testing in Gaza for indigenous cases, which means that by the time an outbreak within Gaza itself has been detected, things will be a bit too late. And that's really the worry about currently what the vulnerability of Gaza towards the pandemic. And so what we have is a situation where as a result of the absence of mass testing or any real testing capacity, it's being replaced by a quarantine because at the end of the day, Gaza is probably the world's most densely populated place. Any meaningful social distancing in places like Jabalia refugee camp or in places like the other refugee camps of Gaza that make up 85% of Gaza's population is pointless. And the infrastructure as a result of decades of war and siege, that hand washing and other problems, what Gaza has in terms of protecting it is a young population, 65% of which is under the age of 35. And so unless there is a rapid increase in availability of testing kits, Gaza will still be very vulnerable because literally all of its testing eggs are in one basket, which is to make sure that incoming travelers returning to Gaza would be all tested. Now, with regards to Lebanon, the situation is a bit different. Lebanon, as you know, hosts almost 200,000 Palestinian refugees since 1948, and another 1 million Syrian refugees since the beginning of the Syrian war in 2011. And with Lebanon's health system, public health system, having been chronically underfunded to the benefit of the private sector, the Lebanese government woke up to really a depleted infrastructure that wasn't going to be able to cope with the pandemic. In addition, the segregated therapeutic spaces that Palestinian refugees and Syrian refugees occupied with regards to the Lebanese health system meant that there were multiple agencies that were trying to address this problem and prepare the refugees under their care. So Palestinian refugees are under the care of UNRWA, which is the UN relief agency that's been providing medical and educational services for Palestinians since 1948. Syrian refugees come under the UNHCR. And then there's a host of international and local NGOs that provide health services. So with regards to the Palestinian response, the UN agency looking after Palestinian refugees decided to try to create quarantine facilities for Palestinians that would be found to be infected in the school system that it runs, so that it can provide some kind of buffer and some ability to quarantine those patients who would otherwise be in the middle of highly populated refugee camps. With regards to the UNHCR and the Syrian population, that wasn't available, and therefore the quarantine service was going to be offered by facilities that the UNHCR was going to rent to create quarantines. Now, what complicates this is a kind of chronic background of anti-refugee political agitation and racism towards particularly Syrian and also Palestinian refugees. And so unfortunately what's been happened is, while the pandemic has been going on, there were political parties from the right who were calling for the army to surround the refugee camps and stop the movement of refugees in and out. And some municipalities where the Syrian refugees were living imposed curfews and banned the movement of Syrian refugees in and out of these towns and villages. So although the lockdown at the moment is working in terms of keeping the numbers of infected patients to a manageable limit, the politics of the lockdown, the way it is exacerbating the political situation on already a fragmented country like Lebanon, is about to cause, in my opinion, as much strife as the pandemic would have. And similarly in Gaza, the situation remains very volatile, and therefore any spread of the pandemic into Gaza will have serious political repercussions to the situation with regards to the Palestinian-Israeli conflict. So I will leave it at that, and thank you very much for inviting me again.
Thank you very much, Dr. Abu-Sittah, and we're really thrilled you were able to triumph over some of the technical challenges and join us today and share those really important insights. If I can ask, we have run slightly over on the time, but if possible, we'd still like to have 10 to 15 minutes for the question and answer component for the webinar. And we've had many fantastic questions coming in, so the ones we don't have time for today will be reviewed and, where possible, updated and included on the IAS information portal around COVID-19 and HIV. So do keep a lookout for that resource. It is updated regularly for those we don't have time to respond to today. I'd like to address the first question to Tracy from the experience in Khalicha in South Africa, and there's two specific questions that have come in for you, but also maybe I can direct it also to others in the panel afterwards. But one of the questions was, how have you managed to convene or not community adherence groups and support for ART adherence in Khalicha during the lockdown? And also, how do you look at HIV testing, diagnosis, and the pathway to initiation on treatment when tested positive during COVID?
Great, thanks. Yeah, those are both very important questions to answer. I was actually just looking in the chat at the one about the adherence groups, and I think very similar to the facility-based adherence clubs, it is about being quite strategic in terms of how those groups still meet and receive their medications. So being strategic about staggering dates and making sure that groups are only meeting, one group at a time, and then allowing a space either in the community or closer to the facility that is outdoors and allows for social distancing, mask wearing, etc. So still going ahead, but making sure that there are the structures in place to make it as safe as possible. And then with the prolonged scripting, giving patients those longer refills, meaning less of those visits needing to happen. So addressing it from both ends in terms of that. And then the second question was about initiating patients at this time.
Yes, that's correct. To test HIV positive during COVID.
So at the moment, I think we've still had very limited. It's still very early on to say how this should exactly work. But patients that have tested positive are following the same procedures in terms of being followed up and receiving counseling and receiving their medication. It's just that they will probably be given slightly longer scriptings initially, about 2 months. And potentially there is room here for us to be a bit more creative in terms of the counseling follow-up and support that they get, to be more telephonic or done remotely. And then something that isn't actively being done, but that we can think about, that I mentioned in my presentation, are for more widespread continuation of testing through things like oral self-testing, and then considering community initiation and management, which is something that MSF has done in Khalicha, but it would probably be really well suited to a time like this to take that further.
Terrific. Thank you very much for that response. If I can direct the next question to Dr. Mussini from Italy and also Dr. Liang in Wuhan. A question has come in asking about any recommendations for supporting the healthcare workforce beyond PPE, and if there are specific lessons learned from the experiences in Wuhan and also in Italy that could provide better support that's not only the hard stuff around PPE, but in terms of workplace practices and rostering or anything practical like that could be shared.
Hello?
Hi, Cristina,
Okay.
we can hear you. Yeah, thanks.
I know, okay. How to support. We had the problem with PPE because it was there was a shortage, but we could manage it. I mean, I think that the first thing, and I'm the director of the clinic, is communication. So it's to talk, to say what is happening, to ask the manager of the hospital for more people, and that's what happened. I have to say that many nurses and also doctors were, as Marta said, were just moved from other department to the COVID department. We have also the psychological support for for healthcare workers, but I have to say that the adrenaline was high but really our hospital put us in the right condition for working. So there was, there was the stress linked to the disease, but we were not, everything was really good because we talk all the time. If there was, we had daily briefing, and also we spoke with the nurses and all the personnel in order to just communicate and discuss eventual decision. So this is the support. I think the support is to talk. We have also the psychologist, but no one asked for a psychologist support.
Great, thank you very much. Dr. Liang, from your perspective, is there anything you'd add to that in terms of support for the healthcare workforce?
Pardon? I'm not sure I understand the constraint.
So I think the question was around some practical ways that, from your experience, you could suggest for supporting healthcare workers in their response and responding every day, day after day to COVID. Not so much in terms of PPE, but some of the structural things like communications that Cristina just spoke to. Is there anything from your experience that you could recommend people put in place to support workers?
The PPE for doctor and nurse?
Yes, sure. In addition to the PPE, so any structural support for healthcare workers?
Yes, for us, I think for me, both doctor and the nurse, if we go to, we have the special areas. If we enter these areas, we have the same. We have the I think that we have the good PPEs. I think the Chinese we are the government and the hospital provide enough the PPE for us, include the mask N95 mask and not the special clothes for me. I think for us, so I think the PPE in our hospital is not a problem.
Okay, thank you very much. One question that has come in that's quite specific to the UK context for Dr. Brofito, but more at the policy response, was if you could say a little bit more about the thinking around this idea of herd immunity, and if there's any evidence so far from within the response you've noticed in the UK, if that's taking effect.
Do you mean herd immunity? So the fact that we believe, this government seems to believe that more people caught COVID, then more people would be protected. I think that's the context. So that is what they were saying at the beginning. So to summarize what happened here, the response was a bit slow. The government had two kind of advisors, the optimist and the pessimist, that they decided to follow the optimist, and then they changed their mind, follow the pessimist, and are now catching up, and I think doing quite well. You probably also heard that our prime minister has been admitted with COVID, hasn't been great. So the direction of how the country is going has changed remarkably, and the long discussions about the herd immunities have completely disappeared. So I wonder whether there was the theory where we actually let's delay the lockdown, let's make sure that the majority of people catches COVID so we can proceed with life as normal because everybody will be immunized. That was a preliminary thought and a preliminary attitude that was then kind of abandoned. I hope that I understood the question and I answered it. So we are not really following that, and we are following what other countries are doing, and hopefully the lockdown is working, and we have another definitely 3 weeks that will continue to work.
Thank you very much. And one final question directed, it could be to any of the panelists, but I think I'll direct it to Graham, please. It's around, I guess, the learning, and came up in some of the presentations about potentially what are some of the aspects from the optimization of services that have been innovated during the context of the response to COVID, but what are the aspects that we might want to consider adopting and taking forward into the post-COVID kind of context? Anything, lessons learned from the context in Cape Town, or if others would like to also jump in on this question, what have we learned and how could we optimize services based on this learning during COVID going forward, specifically in relation to HIV? So Graham, starting with you, but please do add to that if other panelists would like to add.
I apologize, I had to take a call, an urgent call. Just if you could repeat the question.
Sure thing. It was around what can we learn from the response during COVID and how we deliver services in relation to HIV and COVID and other co-infections and comorbidities to optimize those services that we might want to continue with post-pandemic.
Yeah, I think it's really difficult. I think one will only be able to answer that question fully, you know, when the dust settles and when we're over this, because at the moment we're very much in crisis mode. And I think Tracy alluded to some of the facts that the issues that, you know, patients not having to come to the services so regularly so that one can allow the services to focus on people with clinical and adherence problems is possibly one that we can that we could take on board. But you know, at the same time, it's only possibly that we could take that on board. We need to see what the consequences are in terms of having patients having less frequent follow-up. And you know, I think we will only be able to learn when we measure and monitor the outcomes and of what the changes have been. So, you know, I think that we will possibly learn that some of the measures that we've put in place for less frequent visits, for home monitoring, for remote monitoring by social, by electronic platforms, social media messaging to groups, etc., might play a role going forward. But I think we're going to have to evaluate those things with time.
Great, thank you very much. And anything final to add from the UK or Italian experience on that question around optimization, or anything already that we want to take forward?
No, I just wanted to say that, patients with HIV were really in a stable situation. So during the emergency, as everybody said, we just gave more drugs. But now what's happening, about the future, is something that we have really to create, because also the access to the hospital will be different. And this will be, it's not just this 2-month gap, in the services, but it's what will change in the future that will be interesting to follow, I think.
Absolutely. So again, I'm going back to my 2 questions. What have we missed, but what can we improve? And hopefully over the next few months, we'll be able to answer those questions. Stay tuned.
Yeah, watch this space. Yeah, great. Well, thank you very much to all of the panelists for such a terrific combination of very distinct and rich examples from frontline experiences around the world. We really appreciate you giving your time today, and thank you also to the audience who's joined to listen in to this webinar. For more information and to access the presentations, please do visit the COVID-19 portal on the IAS website. You can see the address there on your screens. It is updated regularly, and we hope from tomorrow the recording of this webinar, and also the one from later this afternoon for the time zone that better suits the Americas, will be available to listen again, or also to share with colleagues who you think would also find the content very interesting. Thank you very much to the speakers, and just to remind everyone how difficult it can be to connect across different technologies and different time zones and different bandwidths, etc. So we do really appreciate everyone making the effort to connect and share their expertise with us today. We'd also like to thank the Swiss Agency for Developments and Cooperation, STC, and Merck, Sharp & Dong, our donors, who without their support this webinar series would not be possible. And we'd also like to let you know that your feedback is really important to us. So please do take a minute to fill out a short evaluation survey that you'll be directed to as this webinar closes. And that will help us improve these series and future webinars in the future. There is, as I said, a second session on this topic, sharing experiences and lessons learned from North America and Latin America later this afternoon. That will start at 4 p.m. Central European time. And we'll also have a webinar, the next one in the series at the end of April, is on testing in relation to COVID-19 and HIV testing in the context of COVID-19. So stay tuned as the series develops, and thanks again for joining us today.